Hi, can you hear me?
Yes,
Yes,
bro.
bro.
All right, it's 1 o'clock. So this afternoon's session is all about the brainstem, and the brainstem is one of the more difficult topics to learn or even to teach. So I had a difficult time thinking yesterday how to make it more palatable for you. So let's see how it goes. So same approach as what I did with the cerebral cortex. We'll try to gently break you in to the brainstem. So ever since an article came out before about this painting, right? The painting that is actually in the Sistine Chapel. One of the paintings actually shows Michelangelo's secret frustration. He actually wanted to be a neuroanatomist. So he hid some neuroanatomical structures actually inside his paintings, such as in this particular painting, which is actually a representation, a rather accurate depiction of the brainstem, as you can see here. So we go ahead with the lecture. Learning outcomes. Okay, at the end of this day, you know what a brainstem is. And you don't know, it's not just about knowing what the brainstem is, but you more or less understand why it is shaped that way. Why is it shaped like that? Why does it look like that when we cut it with a scalpel? And soon you will understand what's inside this particular structure. So the basic organization of what's inside, and there are a lot of structures inside. The sheer number of structures inside can be very intimidating. Now, this one we will just mention in passing if this was covered by Dr. Singh, either in OS 204 or in OS 202. The innervation, it is just a reintroduction. We will continue to dig and dig deeper into these regarding cranial nerves. Bearing in mind that these are very tiny structures, so it can be very frustrating if you're there face to face and you're looking at a tiny object, no bigger than uh, a radish or smaller than or slightly bigger than a kikiam. But why is it so important? So the brainstem is the connection between your cerebral hemispheres and the spinal cord to the rest of your body. And almost all animals will possess or have a brainstem because the basic life processes are inside here. Inside your brainstem, the control for your heart rate, the control for your breathing, the basic things that you need to do every day are all inside that small piece of white matter which encloses a gray matter. So, as flash here, you'll get to notice in 205, the structures that you see here are controlled by structures inside the brainstem. A heart can beat on its own without a brain. So it can beat for a while, for around 30 beats per minute, but no one can live with that kind of a heart rate. So it needs to be sped up or slowed down by the brain stem. Basic things that keep you alive, blood pressure. You'll understand all these things when you get to LU4. So, so if you want to take away one point from this lecture is everything that you need to live is in your brain stems. Without your brain stems, you will not be here. You will not be alive. So this is an after lunch lecture. So physiologically, Spanish descent people would take siestas in the afternoon, and that is a way the wakefulness is controlled by the brainstem. Things that you see here, facial expression, the size of the pupil, the squinting of the eyelids, the grimacing. All of these are controlled by your brainstem, in particular the cranial nerves, right? Things like the slit-like pupils when you're exposed to bright light. These are the things that we check, basic things that you check when you see someone who is unconscious. Your eyeball movements are controlled by your brainstem. So, facial expressions, basic functions, things that you do every second or every minute, like swallowing or blinking, all of these are reflexes. And they are not located in the spinal cord, they are located in your brain stems. So by the sheer number of slides I've shown so far, it tells you there's a lot of things inside the brain stem. So as our method here in OS22, we break it down. We break it gently. So flashback to the very first graphic I made when I started teaching. So it doesn't really look like a neuroanatomically correct diagram, but if you can more or less deduce, these are the cerebral hemispheres, that's the corpus callosum, the arrowheads are the thalami or the diencephalon, and that's your brainstem. So anatomists will quibble on defining what the brainstem is because they just say anything that is not cortex below it is brainstem. But technically, the diencephalon, the thalamus itself, deserves its own distinct naming. So diencephalon, thalamus. So we're just basically dealing with the brainstem. So I color coded it in this way so that we know that there are three basic parts. So another take home message after this lecture that brainstem has three important parts. A connection to the cerebral hemispheres, a rather big bellied middle portion which connects to the cerebellum, the cerebellar hemispheres, and the lowermost part that connects to the spinal cord. It looks almost like a spinal cord, but it's not, since it contains some vital gray matter inside. Now, this is a picture I showed you yesterday. So when you flip a brain so that the ventral surface is facing you, now based on what you slightly remember from yesterday, this is cortex, cerebral hemisphere, this one also. This is a mini brain, a cerebellum, then mentally subtracting. So you take away this, take away this, take away this, take away the cerebellum, you're left with this structure here. So the first thing you notice when you open up the brain from a person, you have this elongated object over here, covered with blood vessels. So anything that needs a lot of blood supply is a very important anatomical organ, which tells you how important this object is, which is the brain stem. Another thing, since if this is the very first time you're encountering a brain anatomy being discussed, there will be this structures peeping out from that elongated structure. Those things are nerves. Those are peripheral nerves. And the peripheral nerves will either go to a muscle to innervate it or take back sensation from an organ elsewhere. So they can either be motor or sensory. So those are the few take-home points from this picture. So it's a very small object within a very small compartment when you're talking about the skull. So before it was peeled away like this, it was covered up with meninges, dura mater. There's a dura mater there above the cerebellar hemispheres, which is a very rigid structure. Comparatively, this is almost, like I mentioned, tofu before formaldehyde fixation. So a very tiny, very soft structure, very easy to destroy. But when it is destroyed, we stop living. Now zooming in, on the brainstem, as mentioned, is covered up with pia matter, and in the pia matter you have all these complicated objects seen here: blood vessels, nerves, veins and arteries, and a film of pia matter covering it. So again, if this is the first time you're seeing a brainstem, this is a brainstem. So it is a stem for a very big vegetable up here. Here on this picture, mentally subtracting what you learned yesterday is the cerebral hemisphere. You're left with this object here. And the most prominent thing, peeling away the pia matter, removing all the blood vessels on its surface, you see it's quite a very big bellied structure. So that is the brainstem, the middle portion of the brainstem. Now, if we cut a brain like this, so right down the middle of your brains, we see cerebral hemispheres, one hemisphere, the diencephalon, and then the brainstem down here. So without the dura mater, we have no demarcation where the midbrain begins. So we look here behind. So this is your temporal occipital part of your brain. Underneath that would be a very firm partition of dura mater. And this is the cerebellum. You can see from the picture, the cerebellum is connected to the brainstem. So the stalk here is brainstem. Beyond the stalk is cerebellum. So the brainstem is a stalk for the cerebrum. It also has stalks for the cerebellum. We just flip that same specimen and see the other side, the other half. So practicing. So the thing in neuroanatomy, we tend to be repetitive. We tend to overlap because you cannot remember all these things all at once. You really need to repeat, repeat, repeat. So what we have here, this is a cerebral hemisphere. This is the corpus callosum. This egg-shaped thing here is the thalamus, which belongs to the diencephalon. This brain-like thing here is the mini brain, the cerebellum. So subtract, you get a scalpel and cut it here. Get a scalpel and cut off the thalamus. And then you have a brain stem. So this mentally subtracted structure here is a brain stem. So just remember, when you see it in the actual, it is a very tiny structure, smaller than your hands. Okay, smaller than your hands. What we're seeing here is a picture that is blown up before you, zoomed in, and magnified. The real brains that you see is actually very small, no? Like two of your hands put together. That's how big the brains are. Right. So we zoom in because that is the luxury that we have when we're looking at pictures. We can zoom in and we can see, okay, up here, this egg-shaped structure here is the thalamus of the diencephalon. Then below that egg is this structure from this point down to this point. That's the brainstem. So there will be certain features that are frequently seen which would tell you, oh, this is a brainstem. Okay, one of those things is this very dark band here. You're seeing it in an unusual anatomical picture because what your textbooks would show you would be a cross section of this. So this dark matter here is the dark matter that provides your motivation in life, your motivation to even move. Without this motivation, everything slows down and you're demotivated. So in terms of movements, this is the black substance, or the substantia nigra, or the black substance found inside this uppermost part of the brainstem, which is your midbrain. Down here is a very big belly of white matter fibers which actually connect with this structure back here. This is one of three connections of the brainstem to the cerebellum, and the largest one. It's that large. It actually forms a big bump in front of the middle section of the brainstem. So we call this the base of the pons. This whole thing with the round thing in front is a pons. This is the belly of the pons. Pons means bridge in Latin. So it bridges the two cerebellar hemispheres together. So again, anatomically, we will differentiate. The encephalon is not in the brainstem, but we do have a midbrain here colored in red. So over here, where is it? So we use our mental coloring book and crayons to highlight the midbrain. Okay, flashing it 3 times. And what is found there in the midbrain? So again, this is a unorthodox way to introduce to you the midbrain. It's just to emphasize a point that it connects with the cerebral hemispheres. In fact, it's like atlas, and the shoulders are carrying with it the burden of the whole cerebral hemispheres. So another distinct feature of this midbrain are 2 bumps behind, at the dorsal aspect, if you want to be anatomically correct. So these 2 bumps here form a hill, a pair of hills. So Latin for hills is, or singular is colliculus. In plural, colliculi. So these are 2 hills dedicated for vision and for sound. So remembering that this is a connector of the cerebrum with the body. So things that need to connect with your ears and with your eyeballs have to pass through here to process those 2 kinds of stimuli. So one way, if you want to use mnemonics, imagine this is a boa constrictor that has swallowed an elephant. So the elephant there are the gray matter that processes the visual signals and the sound signals. So more details on that later on. Remembering that this whole thing is a connector. There is that black band again. An advantage of digital uh, editing is that we can crop and zoom this black substance here. So that is the substantia nigra, a feature of the midbrain. So anytime you see that, you're looking at a midbrain. Then the most prominent and the biggest one that you can see, very hard to miss, is the pons. So again, colorified for you is the pons here. So you see a lot of white matter inside, which are actually connections, either with the between the brain and your extremities down here. So you'll learn those tracts later on, the so-called corticospinal tract. And we have fibers crisscrossing to connect with the cerebellum over here, the pontocerebellar fibers, which is responsible for the bulge in front of the pons. So that's the basis pontis, or the base of the pons. So to emphasize a point, so this is the pons, this is the midbrain. So the midbrain has arms which connect with the cerebral hemispheres. Then down here, as if an afterthought, is a connector between the upper brainstem and the spinal cord beneath, inside your spine. So your foramen magnum of your skull forms the barrier or the border between medulla and spinal cord. So they're very 2 different things. The spinal cord does not have any more important vital centers inside. No, you can live with an injury in the upper spinal cord, but you cannot live with an injury here in the medulla. Instantaneous cessation of life if you get a large destructive lesion of this area. So way down here, so like it's just what's left of the brainstem once you take out the pons. Okay, so it also has two hills behind. So the hills behind it are enlargements because there are gray matter passing or underneath this uh, dorsal aspect of your medulla. So again, more on that later. So here is an MRI. An MRI where I blocked out the cerebral hemispheres, I blocked out the cerebellum, just highlighting the brainstem. So an upper part, which is the midbrain, a middle bulbous part, which is the pons, and a tail ender part, which is the medulla. And your marker for that is the foramen magnum if there is a uh, image of the skull inside. So this is an MRI. Bone is not as well seen as compared to a CT scan, which is almost like like an X-ray. Right. So going back to a ventral picture of the brainstem. So when you get a specimen like this, so the most obvious thing would be the base of the pons. The specimen you may be looking at may have varying cuts, no? Because when they extract the brains from the cadavers, uh, it can be quite haphazard. So you can see sometimes a very long brainstem with the spinal cord or very short. No? So you see very little left of the medulla. And then in a uncut brain, you can barely see the midbrain because it's covered up with blood vessels and nerves. So again, this disclaimer: what you see in the atlas is never really like what's in real life. So we also managed to dissect a specimen like this. So we took away the cerebral hemispheres. No, we were able to cut out the thalamus, so we're left with these two arms here. No? So these two arms carry the weight of the cerebral hemispheres and diencephalon above it. This is the pons. This is the medulla. So what is a core feature here? We will enumerate one by one. So again, if you want me to stop, just tell me to stop. We're trying to go through this very gently, but we will stick to the 4 o'clock when we need to stop. But I will continue to record. So that's your midbrain. So I'm using colors to highlight. So those are the so-called cerebral peduncles or stalks. Peduncle means stalk. It's a stalk meaning it connects to something, which is upwards the cerebral hemispheres. This is the pons, the biggest part. And that is the medulla. So we will segment this lecture. We will talk about the midbrain, then we'll talk about the pons, then we'll talk about the medulla. Okay, always bearing in mind it's quite overwhelming. So if we need to zoom out a bit or zone out a bit, it's alright. Okay, so for now we zoom in. We zoom into the specimen and look at the midbrain. So two arms connecting to the cerebral hemispheres. So of course, when you raise your arms up to the ceiling, there's always be an empty spot where your head or your face should be. So that empty spot here, so it's a cavity. So anatomists like to call these cavities fossa. So anything that is a fossa, they call it. So this one, it's a fossa between the two cerebral peduncles. So therefore, we name it interpeduncular fossa, meaning it's just a fossa between the two cerebral hemispheres. Again, this picture has been zoomed up several times. So what you see in the actual specimen, it's that's the basal, that's the interpeduncular fossa. It's actually quite small. Okay, but why would we even mentioning it unless it was important? So it's important because of structures that pass through here. So more on that later. Okay, so in an undissected brain specimen where you have not removed the PM matter and the dura yet, so this is more or less what you would see. uh, it's all covered up with pia and dura, and you see the cranial nerves peeping out, no? Extruding from that dura mater, going to their different foramina in the skull. So once you've taken away the skull, you're just left with the space. No? So when you take out the brain for the very first time, all the fluid oozes out or drips out. So it is a space. Therefore, in life, it once contained fluid. So again, anatomists like to name everything. No? So the interpeduncular fossa over here contains cerebrospinal fluid. So this is how it looks like. Since it is a cavity, it is a container for fluid. We call this one when it is filled with CSF usually, or blood unusually if there's an aneurysm that ruptured there. We, it's a cistern, meaning a large container of fluid. Normally contains CSF, abnormally contains blood from a ruptured aneurysm, or pus. Pus, nana. It can be covered with pus if you have an infection here. Right? So that's the basal cistern if you're a radiologist. But we call it interpeduncular fossa, or the basal cisterns. You see, it's an area empty usually, other than the arteries and the nerves that pass through here. Another cistern. So a cistern, meaning in life, it contains a lot of fluid here, meaning it's a space here. So the angle formed by the peduncles of the pons, the connecting to the cerebellum, and the space here formed by the medulla, so it forms an angle, no? The cerebellopontine angle. So the cerebellum with reference to the brainstem. Again, why do we mention this? It is a space, and any space has contents, not just the cerebrospinal fluid, but also nerves that pass through here. So why is it relevant? Because in LU4 onwards, LU6, you'll be taught that certain tumors grow here. Tumors can grow out from the nerves, it can grow out from the meninges, or it can grow out from the cerebellum itself, or from the blood vessels that reside here. So, emphasizing, it's a cistern, it's a space, it has CSF in life, as well as the cranial nerves that pass through here. So, just name dropping a few of the nerves that pass through here, and we will just repeat this later on. The seventh facial nerve, or the eighth cranial nerve. So don't need to stress so much about their names at this time. Just know that there are nerves passing through there. So it also helps you remember if you parcel out the brainstem into different components, so it doesn't get overwhelming. So again, some sulci which are relevant. So the sulci, and everything has a sulci when you're talking about the anatomy. Now, why would I mention this sulci? I'm not fond of defining all the different sulci here. So this is just the sulci, the groove between the large belly of the pons here and the medulla down here. So why bother mentioning this sulcus? It's because there is a cranial nerve that comes out here all by itself in the middle, as well as two here laterally. So we get to them in a while. This one I'm just mentioning as a form of completion because this is a groove that continues on in the spinal cord, as will be lectured by Dr. Seng. So again, I do not bother lecturing on sulci unless there's something relevant to this. So we're introducing to you two sulci here laterally, no? Because wherever there is a bump, as I mentioned in the cortex, in the cerebral hemisphere lecture, wherever there are ridges, there are valleys. No? Wherever there are mountains, there are valleys. So there are mounds of brainstem here divided by grooves. So this one, since it's a small one, we call it a sulcus, and a cranial nerve comes out from here. So that mound of brainstem here in the medulla is called the pyramid. Not because it is pyramid shaped, but because of a tract, a fiber tract that passes through here, the pyramidal tract, and does not look like an olive, but they named it an olive lateral to that pyramid. So pyramid, olive are the two mounds of flesh there at the base of the medulla. So wherever there is a crease or a sulcus that is mentioned by Dr. Pascual, it means something comes out from there. And as you can see here, peripheral nerves come out from those creases. So wherever may butas, may lalabas, no, or may papasok. So we just flip the specimen on its side. So we see the continuation of that pontomedullary sulcus. And I only mention this because there are two more cranial nerves that arise from here. I already mentioned them earlier. The seventh and the eighth cranial nerves come out from here. There you have the anterior median sulcus, which is shared with the spinal cord. You have the anterolateral sulcus, and the posterolateral sulcus is now visible if you flip the specimen to the side. So again, this is the pyramid, and that is the olive. And this is the CP angle, or the cerebellopontine angle. So we stop here and take a look at a 3D website, the Neurosurgical Atlas website. And we go full screen and wait for it to load. So any questions at this point?
Hi Doc, banggitin ko lang po, sometimes lang po naglalag, pero comprehensible pa naman po.
Alright, sorry. The audio or the video? Or
The audio po, the video
okay.
is
So this is from the Neurosurgical Atlas website. So we are not neurosurgeons, but we are borrowing their 3D models. So first, this is for reference. This is the posterior fossa of the skull. So I'm gonna take away the skull and zoom in a bit. Okay, so before we get lost. Okay, so this is a brainstem. You're looking at it from the anterior. So I right click to drag it and then I rotate it with the left mouse button. So up here, that is actually the diencephalon. This is actually the optic nerves, the pair of optic nerves. So atop, so this is diencephalon, hypothalamus, and this stop over here is the midbrain. So just to show you slowly, so let me drag it. So orienting you, this is front, this is the back. So the midbrain is this structure that we're looking up here. Those are the two mounds or hills, the colliculi, the superior one and the inferior one. Superior colliculus, inferior colliculus. So that is the only thing that we see at the back of the midbrain. Then we rotate a bit and see, oh, below that inferior colliculus there is a cranial nerve coming out of there. The only one that comes out from the back. So I will let you know which one that is later, but for now let's just call it the fourth cranial nerve. Cranial nerve number 4 comes from the back. This Let me zoom in. These are the two cerebral peduncles. So this space inside is the interpeduncular fossa. So a cranial nerve comes out of that interpeduncular fossa, and the only one that does so. So that is the third cranial nerve. So more on that later. So show you the third cranial nerve. So that's it for the midbrain. Okay, so we zoom out a bit and we rotate. So this humongous thing here is the pons, no? The base of the pons. It connects with the cerebellum. So if you rotate it, let me remove this first. So the large base of the pons in front, and then we rotate it to go look at the back. We see this cavity here. It's a cavity. Oops, sorry. So you have a cavity here. Actually, it's one half of a cavity. So this is the floor of the fourth ventricle. So should be lectured to you by Dr. Baticolon. So the fourth ventricular floor. What else do we see here at the back of the pons? So here, which has been cut already, is that massive basis pontis connection with the cerebellar hemispheres. So these large stalks that have been cut here is the middle cerebellar peduncle. Now, for there to be a middle cerebellar peduncle, there has to be something superior and something inferior to it. So here, also in the pons, is the superior peduncle. So it is located in the pons, but its target is there in the midbrain. So it goes up into the midbrain. So superior, middle. That's for the back of the pons. So here, if you look at the base of that fourth ventricle in the pons, you see there's a mound, a ridge here again. So wherever there is a ridge means there's something important underneath. So you will get to know what's underneath that when we go into the cross section of the spinal cord. So we zoom out a bit so we can rotate it. Okay. So if you zoom out like this, you see the base of the pons, and then on piercing through that the fibers which will eventually form the middle cerebellar peduncle is this large, very obvious cranial nerve. So this large cranial nerve here that splits into three. So they're called the three twins. The trigeminal nerve, meaning this large nerve splits into three, which will supply the sensation of your face as well as move the mandible, if you recall from OS 204. So that is the most prominent thing here in the pons. So we mentally subtract. No, so this is the midbrain, this is the pons. Okay, you forget about these two first, and then we focus here at the lowermost part. So from where the cursor is, which is already spinal cord, and you see that sulcus there, which continues on in the spinal cord. Now, the difference between this medulla and the spinal cord beneath it is you do not see these pyramids anymore. So these pyramids contain those fibers from your motor cortex. So they're on their way down. And as I told you yesterday, they are meant to target your extremities on the opposite side. So if this is coming from the right brain, it has to find its way to the left arm and the left leg. So once it reaches this junction between the medulla and the upper spinal cord, that's when it starts to cross over. So This area where that pyramid starts to grow smaller and smaller is actually where the crossing takes place. So the term decussation. So decussation means crossing over. So they're crossing over here. So pyramids with its pyramidal tract inside crossing over here at the junction of the medulla and the spinal cord. Now, remember those sulci between the pyramid and the olive. So we zoom in some more. Drag it down here so you can all see it. So this is the pyramid and this is the olive. Now, in that first sulcus between the olive and the pyramid, you have these rootlets of a peripheral nerve which will target your tongue and move your tongue muscles. No? We will just call it the 12th cranial nerve for now. So the 12th cranial nerve exits from the sulcus between the pyramid and the olive. So here on the right side and here on the left side, the rootlets of the 12th cranial nerve. Okay, so we settled that. Only one cranial nerve exits through here. Now, before we forget, since we already went from pons to medulla, there is a junction, that so-called pontomedullary junction. Let's bring it down here to the center. Why did I mention it? Because there is a very long cranial nerve that comes from there. Now, if you zoom out and zoom out and zoom out, and we rotate, there is a very long nerve that exits there to go to your eyeballs. So that is a very long course for any nerve to go. So very prone to be damaged or to be stretched by anything anywhere from here in the brainstem to the orbits where it's supposed to come out. So that is the 6th cranial nerve. So later you'll get to know what it does. So if there is a 6 and a 12, it means there's a 7, 8, 9, 10, 11 in between. So to continue on with that sulcus here, the pontomedullary sulcus, if we rotate the brainstem like this, we follow the sulcus and we see these two cranial nerves here. One goes to move your facial muscles, whereas the other one goes into your cochlea and your labyrinth. So that cranial nerve, so the modeling of this one's not perfect, but it shows a more medial facial nerve or 7th cranial nerve and a more lateral cranial nerve 8, which will split into one that targets your hearing and one that targets your balance. So that's the 8th cranial nerve, and with that is the 7th cranial nerve. And if you look here peeping underneath, if you can see it, there is a small sensory nerve that travels with that facial nerve. So it's on its way back in here to go into the medulla. So that one carries your taste fibers. Still part of the 7th cranial nerve. Alright, I still hope you're with me. So we mentioned where there is a 7 and 8 and a 12, it means there's a 9, 10, and 11. So if you go back here, you know that the 12th cranial nerve comes out between the pyramid and the olive. Here behind would be the rootlets of 9, 10, and 11 cranial nerves. So we're looking at the rootlets here on the sides. Here, so they appear to form single nerves when they're out here, but their rootlets betray their true origins. They belong to the same gray matter inside. So more on that later. So there's a lot of sharing going on between the 9 and the 10th. And even the last one, if we drag this down here, you have the so-called spinal accessory nerve or the cranial nerve 11. So it betrays its true nature as well. It is actually a spinal nerve that became a cranial nerve because simply because it went inside the foramen magnum. So it is a spinal nerve that is also a cranial nerve, and it travels together with the, as you can see here, so that's the 11th cranial nerve. It travels together with the 10th, the 9th, and the 12th cranial nerves. Alright, so to complete the picture, we go behind the medulla and we zoom in, and we don't have this luxury with formalinized specimen or even the plastinated specimens, which you are privileged to be among the first students to use it, at least in UPCM. So here we're looking at the back of the brainstem. So this one is pons. You see this cavity shared with the pons also ends here in the at the back of the medulla. So it forms a triangle shaped floor here at the back of the pons and medulla. So if you zoom in here, that forms a very triangular shaped apex over here. So the apex of that floor of that fourth ventricular cavity is known as the obex. So apex obex. Why am I mentioning it now? Because if you got very dizzy looking at this imaging, I am actually stimulating the structure found underneath here. So we'll see that later in the brainstem cross section. But that is your vomiting center right underneath that. So anything that stimulates it, either you're very nauseous from something that you ate, or you came from a carnival ride, amusement park ride, or you're really just very nervous, there's a stimulation of your vomiting center inside that, underneath that obex. Alright, I hope the 3D models serve their purpose for you, because it's really hard to lecture on the brainstem without you actually visualizing. So we exit the full screen and we go back to that to reach the part of the part 1. So this is what we saw earlier in the 3D model, the back of the midbrain with the hills, the back of the pons and medulla, which contains the diamond-shaped floor, and that vomiting center behind. And not so nice picture, but before that 3D model came along, this is what I had to show LU3 students. So that's the medulla, that's the pons, and the midbrain. Right. So this is a nullity picture. So you start to see a pattern if you flip the brainstem and look at the dorsal part. Expect to see a diamond-shaped object there. That's the floor of the fourth ventricle. Okay. Back of the midbrain, the pair of hills, the superior colliculus, the inferior colliculus, collectively known as the quadrigeminal. So four twins, or how do you call it pag hindi triplets na four, no? So quadrigeminal, no? Four twins forming the hills at the back of the midbrain. So another one of those commissures that I just mentioned in passing yesterday, the posterior commissure, also an object that you will not even see in the specimens that we cut. Very hard to preserve this. So it's a connector between the diencephalon with itself. Diencephalon half the right with the left. So we will see significance later on when we actually test your pupillary light reflex. You see this in films, in cinema, people checking with a light, flashlight, the eyes of an unconscious person. So continuing on, that's the midbrain. again, I keep repeating myself. So visual stimuli, sound stimuli. This came from upstairs in the diencephalon from the optic nerve, whereas this came from downstairs from the eighth cranial nerve. Okay, so flashing the pictures just to emphasize what I showed you earlier in the 3D model. The middle cerebellar peduncle. The middle cerebellar peduncle. So from two vantage points, from lateral view, from dorsal view. So knowing it connects with the cerebellum, one of three connections, giving rise to that massive belly of the pons. And then I mentioned the connections with the cerebellum. Technically, these are both from the pons, but the superior cerebellum goes into the midbrain. I don't pay so much attention to this, but because it is in your books, we just take note that there are Latin terms for these. Their significance, I am not so sure. So definitely this one's obvious. No, this is an arm connecting to the pons, but this one, I'm not quite so sure. Right? So by their mere presence, those peduncles form a kind of roof over the brainstem, together with the cerebellum itself, to enclose a cavity there for cerebrospinal fluid, the fourth ventricle. Okay, so you will see the mounds of tissue here are actually containing cranial nerves which are voluntary. So underneath this are the voluntarily controlled parts for your eyeballs, for your tongue down here. So anything you can voluntarily control, it's gray matter, its neurons are found inside here. Okay, and then that is the medulla, which some authors like Nolte would say it resembles an ice cream scoop, where the upper half of that medulla with the floor of the fourth ventricle is called the rostral medulla, and the one behind or below it is called the caudal medulla, which does not contain any remnants of that fourth ventricle anymore and actually resembles a spinal cord beneath it. And that's your obex once again. So again, double, triple, quadruple emphasize the obex. Okay, if you know the proper teaching styles, whatever the lecturer emphasizes is usually what they ask. It means it's important. Now with the brainstem, there are so many things, so we emphasize what is important. So this becomes important as you go up into LU4 and LU6. Alright, so just continuing on, I mentioned the foramen magnum. The space in front of the brainstem contains CSF as well as the blood vessels there. And that's how you see a brainstem minus the cerebral hemispheres. It's always how it appears. It's a mess. But you have a constant singular large artery in front of that pons. No? So since it's in front of the base of the pons, that is the basilar or basilar artery in front of it. So more on that when we go into the blood vessels. So continuing on, the meninges were lectured to you. I mentioned to you that the brain is like tofu. And you know what happens to tofu when you try to handle it? It breaks. So imagine something as hard as a tablecloth, no, or a placemat versus tofu. The tofu loses out. No? And this is the meningeal coverings of the cerebellum, the tentorium cerebellum, which can actually destroy your midbrain. No? If something is pushing down from above, like a expanding brain tumor or a very large stroke. So that those are the parts of the skull which Dr. Singh would have mentioned already, the clivus. So your cranial nerves will penetrate, no, any hole that they can find, they will penetrate there to go to their destinations. Right? I will not mention this anymore since Dr. Carrillo would have mentioned this sinus in front, and Dr. Sang will mention it also if he has not already mentioned it. Okay, we show an intermission slide here, of why the brainstem is important, no? Because, well, this went way past the brainstem. This is a feeding tube which was inserted into the nostril of a person and ended up inside the ventricles of the cerebral hemispheres up here. So it passed through the sphenoid sinus probably and into the ventricle system here. So this picture is just meant to emphasize that the cranial nerve foramina are not there to torture you, to torture you into remembering them, but to just tell you that the cranial nerves from the brain, the nervous system, will exit somewhere. And wherever they may exit, they can be damaged by something that should not be there, like a tumor inside the sphenoid sinus, or a tumor that grows from the bone or the cartilage of the clivus down here. Right? Foramen magnum is the exit, of the brain stem into when it becomes the spinal cord. So on an eggshell CT scan, so only one plane for CT scans, you see this round hole here, wherein you can peek into and see the brainstem and the cerebellar hemispheres. Right? So that is the brainstem. So I'll take questions before I go to the part 2. So are you all holding up okay? Are you still awake?
Yes,
Take
Doc.
a 5 minute break. Would that be okay?
Yeah, sure. Take a 5-minute break. Okay, just to resume. Hope 5 minutes was enough. So I really had to think hard last night, which the sequence to present the different parts of this lecture. So I had to think so hard I fell asleep. But I guess it's still the best sequence to go. So after I show you the brainstem on its outside, we stay on the outside and we go into the cranial nerves first. So I like to say this is a Bobo friendly OS, Bobo OS 202. So there are no stupid questions here. So you're free to ask either privately or at a later date or through your liaison officers. All right. Uh, One of the questions asked privately was about what happened to that patient where the feeding tube entered into the brain. So the patient
Doc?
survived. Sorry, I was muted. Sorry. So the sequence we will follow will be we'll stay on the outside. No? We stay externally, then we'll go internally. So we'll talk about the cranial nerves first. So I already flashed this slide. So you're free to ask any question. So tabula rasa. So no one's expected to know more than anyone else here, regardless of your pre-med course. Right? Hope you're still awake. We'll talk about the cranial nerves this time. So I already introduced them with the 3D model earlier from the Neurosurgical Atlas. So a nice clean specimen from the University of Utah showing you all cranial nerves. So cranial nerve 1 was what I showed earlier since it's technically arising from the telencephalon. Find it here in the sulcus near the straight gyrus of the frontal lobe. Cranial nerve 2 is actually a extension of the brain, not actually a cranial nerve. It's a tract actually that connects with your eyeballs. So technically part of the diencephalon, so technically not part of the brainstem discussion. I did mention here in the interpeduncular fossa or cistern or basal cistern. So all those are all the synonyms that the radiologists like to use. This is the third nerve, so we now give it a name, oculomotor. So oculo means eyeball, motor means movement, so moving the eyeball. Since it controls most of the eyeball muscles. Then, peeking out here, very difficult to preserve in cadaveric brains, no? Unless painstakingly dissected, is the fourth cranial nerve, which you saw earlier arises from the back of the midbrain. That is the trochlear nerve, meaning it innervates a muscle that has a pulley, no, the superior oblique. So very difficult to preserve because it passes in between the temporal lobes uncus over here, the parahippocampal gyrus, to go to the skull, to the orbit. No, it's a very tiny muscle, so you can see the more innervation the cranial nerve has or does, the bigger it is. So the easier it is to spot. But for a cranial nerve like this one that innervates only one muscle, it's quite tiny and very prone to be destroyed during the extraction process, similar to this one here. This is cranial nerve 6, which moves the lateral rectus. It abducts the eyeball, hence it's called the abducens nerve, or cranial nerve 6. The two cranial nerves I name dropped earlier arise from the lateral part of that sulcus, 7 and 8. So 7 is the facial nerve, which I saw in the schedule, had an SGD assigned to it in OS204. And then there's the 8th cranial nerve. So there in the 3D model, you saw it is actually a combination of two special sensory nerves fused together. And then here, the only nerve by itself in this sulcus over here, the 12th cranial nerve. And then the 9th, the 10th. So the 9th is the glossopharyngeal. So glosso means tongue, pharyngeal means pharynx. So mainly a sensory nerve of the throat and tongue. And the vagus nerve, the wanderer. So it wanders down all the way into the viscera in the thorax and in the abdomen. Followed by the spinal accessory, which comes from down here, which enters the foramen magnum as your accessory cranial nerve. It's a spinal nerve that is an accessory cranial nerve. So just coloring for you. I'll just color and not name them anymore since they are labeled. And what they do. Optic nerve. So we're looking at little things. And this will be discussed by Dr. Batigalon. So it's actually a tract coming from the brain, meaning it has a meningeal covering, and it also has a special cell which is not found in the periphery. So it's not a peripheral nerve, it's actually an extension of the brain. So it's a bit true when they say the eyes are the windows of the soul. Technically, the eyeballs are the windows of the brain. Then down here, so we like to break things down so we don't get overwhelmed. You don't bite off more than you can chew. Here, at the level of the midbrain, you have cranial nerve 3, which is your oculomotor. And your, it's, well, if you really want to remember just one thing about cranial nerve 3, it's what you're testing when you're checking for the reaction of the pupils to light, but not the main thing. What she can do is actually oculomotor. No? So she's using her two medial recti at the same time. So, so oculomotor nerve. These are just showing the different movements. No? So looking up, looking towards the nose, looking down, and what she was doing earlier, no? Medial rectus. So I keep emphasizing this. What no matter what LU you are, LU3 or LU6, LU7, the uncus and its relationship with the oculomotor nerve. So, knowing that the oculomotor nerve is in charge of constricting the pupil, the moment a person that you know or a loved one's pupil is suddenly no longer reacting to light, that is a danger sign, and you need to bring that person to the emergency room. This is a bad sign when you no longer constrict your pupil on one side, meaning your third nerve here is being compressed against the dura mater. So that leads to an inequality in the size of the pupils. So this is what we call anisocoria, and when we say it is significant, it means we're talking about the bigger pupil here, right? So just like we saw the spinal nerve of the rootlets of the hypoglossal, the cranial nerve 12, the rootlets of the ninth, the 10th, and the 12th. The rootlets of the third nerve are not visible because they actually converged inside the substance of the midbrain before it comes out like this. So it emerges into the space here as the oculomotor peripheral cranial nerve. So why am I emphasizing this as early as LU3, as early as the first lecture on the brainstem? So cranial nerve 3, what you need to remember, the connections from your brainstem to your pupils is just here on the outside of that cranial nerve 3. Okay. Whereas less well, not because they're less important, but those which will elevate your eyelids are safely found here on the inside. So they're safe here inside, further from injury. But when you have something pressing down on the nerve, the first thing that you lose is the ability to constrict your pupils. So you're destroying these fibers which are superficially located within that cranial nerve 3, knowing that the cranial nerve 3 contains several fibers for several muscles coming from several gray matter inside the midbrain. So it's a collation of several smaller cranial nerve rootlets. Whereas, and you will learn this from LU4, LU6 onwards, the blood supply of a nerve unfortunately favors the ones on the outside compared to the ones on the inside. So the fibers here on the inside, if there happens to be a blockage here in the artery that supplies the nerve, will cause, if there's a drop in the blood pressure or there's a blockage here, the ones furthest from the blood supply will suffer the most. So the ones on the inside. So in people with long-standing poor blood sugar control, they can get damage to their nerves because their arteries are clogged up with cholesterol deposits. Right. So all those collated and collected cranial nerve rootlets inside the cranial nerve itself will now pass into the subarachnoid space, into the bone, and into the dura of the skull, of what Dr. Seng lectured on. It will penetrate that venous channel inside the cavernous sinus, and it will be one of the several cranial nerves that are found on the wall of that cavernous sinus. So I'm not sure how detailed OS204 went into this. I'm just refreshing you or just telling you for the very first time. Cranial nerve 3 is there on the lateral wall of that cavernous sinus behind your eyeballs. So together with the other cranial nerves, and exit via that fissure in your orbit. So that fissure in your orbit, in the upper part of your orbit, or the superior orbital fissure, is where most of the eyeball controlling nerves will exit. Whereas the vision has its own dedicated canal here for the optic nerve. Similarly, that nerve we saw exiting beneath the inferior colliculus will also target the same fissure in your orbit. So same destination as the oculomotor nerve. That tiny little trochlear nerve. So what happens? Uh, it has a very specific muscle with a very specific action to rotate the eyeball inwards. More details on that when I lecture on how to test the motor cranial nerves in a few weeks' time. So that's trochlear nerve. So we've already covered 4 out of the 12 cranial nerves. Right? So very repetitive the slides. So same destination as the cranial nerve 3, meaning it has to pass through the same area. So the subarachnoid space into the dura of the skull, under the dura, to proceed to that superior orbital fissure. Inside, first it must traverse this venous channel, the cavernous sinus. So here visualized for you to get to its target over here. So where would we find it? It's found together with the cranial nerve 3 here in the lateral wall of the cavernous sinus, and exit the same fissure over here. So, well, flashing this now, I hope it has been mentioned in 204, and you'll overemphasize it, emphasize it repeatedly. SO4, if you want a mnemonic. Superior oblique is innervated by cranial nerve 4. So it's located up here, and the distinction is there is a pulley for that muscle. Hence, the nerve to that pulleyed muscle is called the trochlear nerve. Now, again, segmenting the brainstem lecture and the cranial nerve so that you do not get lost here. So now we focus on this part, the part where we saw the cerebellopontine angle, the part where we saw the sulcus separating the pons and medulla, and the pyramids versus olives over here. So first things first, the largest cranial nerve that is often cut as well when extracting the brains are the trigeminal nerves. So when you see them in the brain specimens, they're usually actually stumps already. So the trigeminal nerve, so 3 twins, they will diverge into 3 different subnerves. The ophthalmic, which will target your forehead, the maxillary, which will target your cheeks, and the mandibular nerves, which will target your jaws. So here, the stump of the trigeminal nerve. Can't miss it. It comes out there at the penetrating the middle cerebellar peduncles, crisscrossing fibers. So De Meyer is actually quite morbid, in the way he illustrates things. So imagine if a scimitar cut off a person's face. That is what's supplied by the trigeminal nerve. So this is my version of De Meyer's scimitar face, but more attractive. So ophthalmic, maxillary, and mandibular divisions. Why am I showing her face? To emphasize here, no? Because even at during the neuro-OSCE, some students still test for the facial sensation by putting the stimulus here on the skin of the angle of the jaw, which is not a trigeminal distribution. So as early as now, I'm showing you this girl's face for emphasis, right? So middle cerebellar peduncle, trigeminal nerve. So all the nerves will traverse the subarachnoid space and target their respective foramina at the base of the skull. So the trigeminal ganglion or the semilunar ganglion will rest on the skull in what we call Meckel's cave. So Meckel's cave is just an area of the skull and where the trigeminal ganglion can be found. So it is actually a area with boundaries. So the boundaries would be mainly skull, no? Skull and dura mater to form the so-called Meckel's cave. So here they cut away portions of the base of the skull to demonstrate where the trigeminal nerves will start to split and split into their smaller roots. So these are the boundaries of the Meckel's cave. First, in front, the base of the skull, or the clivus. Then you have the cavernous sinus anterior to it. Above it, the dura mater of the tentorium cerebelli, and on the side, the skull's petrous portion. So this is medial, this is lateral. Again, drawing from, well, the overwhelming information that you got from OS 204. So demonstrating those structures, the cavernous sinus is found in here, the venous channel. This is the tentorium of the cerebellum. So that's where your trigeminal nerves will be found in their Meckel's caves. Okay, so once they've penetrated and they're resting here in the semilunar ganglion, they will now diverge, as you would have learned from Dr. Seng and from 204. The V1 division or ophthalmic has its own target, which is your foreheads. So to get to your foreheads, they have to go through the cavernous sinus into the superior orbital fissure. Whereas the maxillary division, which will target your cheeks, has a much lower destination. So instead of going into your orbits, naturally, they will go towards your cheeks, your maxilla. So they go via the foramen rotundum. And the biggest root, or the biggest division, which is the mandibular division, has no reason to go into the cavernous sinus because its targets are beneath in the mandible. So instead, it goes through its own large foramen ovale. I hope that makes it easier to remember. Right? This picture also makes it easier to remember. The targets tells you where they will penetrate. So supraorbital fissure, foramen rotundum towards the cheeks, or the foramen ovale here to go down towards the mandible. Right, so here within the cavernous sinus, we already know that the V1 and V2 are inside the cavernous sinus. The V3 does not enter the cavernous sinus. So they line up along the lateral wall with the third, the fourth, and the V1, V2. Right, so this is a close-up dissection of the trigeminal ganglion. That's the cavernous sinus. This is the V1 exiting through there, whereas the V2 passes by the cavernous sinus but goes out through the foramen rotundum, whereas the V3 goes down here in its large oval exit. Right, so now we get to the next few cranial nerves. the abducens, which is the sixth, the smallest and the most medial of the cranial nerves that exit through this sulcus here, the junction of the pons and medulla. So demonstrated here, the lateral rectus, meaning your eyes move to the sides, no? Meaning your eyeballs look towards the side or your ears. The abducens. So further laterally would be the facial nerve. So we saw earlier in the 3D model a small sensory root for taste, known as the nervus intermedius, and a larger root because that facial nerve innervates a lot of your facial expression muscles. So it must be a large nerve. But vestibular nerve. No? So this is the fusion of two cranial nerves, a division for hearing and a division for balance. So that's the midline, that's your pontomedullary sulcus, that's the abducens, the facial nerve, lateral, and more lateral, the vestibulocochlear nerve. So just like that, we covered half of the cranial nerves already. Now we go to the what we call the lower cranial nerves. Physically and literally and figuratively, numerically. So here demonstrated by this uh, diagram now. These two nerves here. It's a oversimplification. So these are rootlets that form a peripheral nerve because they innervate certain things in different areas. Glossopharyngeal. Sorry, it's a wrong spelling. It's only two S's. And the vagus nerve. So the spit laugh, a productive measure against choking on your water when you're laughing. So two components, sensory and motor, mainly motor. So what if your classmates ask about the vomiting reflex? Uh, the expulsion of the food contents itself is motor, and that is subserved by your vagus nerve. The sensory part, the feeling of tickling at the back of your throat, which is a ninth cranial nerve domain, as well as irritation of your stomach, is also via the vagus nerve. So it's a quite mixed. That's why the way they teach this in pre-med, that's why you should all consider yourselves tabula rasa because the way it's taught is not the way it should be taught. Because the way it is taught before med school is they stop here. They teach cranial nerves as just extensions of the brainstem and nothing else. They go inside. And when they go inside, it's a totally different story. Okay, so taste sensation and the gag, meaning the sensory part of gagging is mediated by your ninth cranial nerve. Whereas the actual uh, execution of the vomiting and the other reflexes is a function of the vagus nerve. And you can see it travels to a lot of areas here within your bodies, no? In your thorax, in your lungs, in your heart, the abdominal organs, as well as the pelvic organs, in your colon, your rectum, everything. Alright, this is just to emphasize how your small vagus nerve has a lot of targets. So the swallowing reflex, the motor action is a vagus nerve function. Okay, so now back to the hypoglossal nerve. Hypo meaning below, glossal, the tongue. So the nerve beneath the tongue, and it is a voluntary motor function. The movement of your tongue most of the time is voluntary. Okay, so literally beneath the tongue over here, as you should have learned or you may have forgotten from head and neck. You know? It has its own canal within the skull, exit and innervates the extrinsic muscles of the tongue. So just a run through already of their exits. The sixth nerve exits, it burrows underneath the clivus dura mater, a small obscure canal called Dorelius Canal, to penetrate into the cavernous sinus over here. So a small hole there, cavernous sinus over here. So inside the cavernous sinus, the special thing about the abducens is it occupies the medial wall, as in it's the only one there on the medial side. Important, again, aside from its very long course, its proximity to the internal carotid canal here within the cavernous sinus. So little things that you will learn as you become a doctor. When you see something wrong with the lateral rectus innervated by the sixth nerve, it tells you one thing. It doesn't tell you where the problem is, but you know that there is a problem inside the brain. So, target a muscle here in the eyeball, hence, exit will be in the superior orbital fissure. Seventh nerve, eighth nerve will have their own shared exit. So they're very close to each other as they exit the brainstem, and they'll still remain very close to each other as they exit the skull inside the internal acoustic meatus. So that's where they end. That's where they part ways. After that, the facial nerve will go into your very hard petrous bone and form its own canal, the facial canal. Whereas the cranial nerve 8 will now reach its target, which is the labyrinth. Right? Just flashing pictures. No? We don't need to dwell so much on this. And the final exit, after giving off a muscle for the inner ear, the stapedius, it gives off the chorda tympani, which is a taste receiver from the tongue, before it goes to its facial expression muscles out here in front of the cranium via the stylomastoid foramen. Alright. As to the 9 and 10th, and the 11th. So mentioning here that the 11th is actually a spinal nerve and not a real cranial nerve based on its origins. It originates from the spinal cord, but is named as a cranial nerve because it's inside the cranium. Okay, so it's the only one that stands out. So spinal accessory, emphasis on spinal. So the spinal accessory will join together with the 9 and 10 to exit the so-called jugular foramen, a very large hole at the base of the skull, because that's where the internal jugular vein exits. So distinction, it goes in to the cranium, then goes out the jugular foramen. So a spinal and cranial nerve at the same time. Then the hypoglossal nerve, as mentioned earlier, exits its eponymous hypoglossal canal. So a very tiny canal for a nerve all by itself. Alright, so now we've demonstrated, you know that cranial nerves exist. That's one. If this is your very first time to encounter cranial nerves, they come out from the base of the brain. They're inside the pia mater. So in the pia mater, they're all jumbled up with the blood vessels there. So blood vessels themselves can irritate those cranial nerves. They can press on them. If there's an aneurysm there, it can compress on them. Or even anatomically, some nerves pass between two arteries, and the nerves can be compressed by those two arteries. Or the large nerve here, the trigeminal, can be tickled by a blood vessel close to it. But the ticklishness of the trigeminal nerve means suffering for some of our patients because they develop pain in their face. Each time they laugh, each time the electric fan blows on their face, they get pain, the worst pain of their face ever. So more on that when you get into LU4. Okay. So because of this PM matter, if there is blood there, if there is pus there, it's gonna engulf everything. Because it's a kind of a trap, that PM matter. And down here, the cranial nerves also very well, very close to the blood vessels, very close to the cerebellum. And because they're close to the cerebellum, something can grow on the nerve and press on the cerebellum, or something can grow within the cerebellum and press on the nerves as well as the brainstem here. So possibly, if you might be given opportunities, if ever you're assigned patients in the latter portion of OS202, we cannot choose our patients, so value the patients that you get to see, because not all patients are the same, and they will all have interesting findings when you examine the cranial nerves. Alright, so that is what you will see in the lab. That is what you'll see online in pictures. Finding your way around it, navigating your way around it is a challenge. Right? So just by looking at it, you more or less know already. So this is the second time, third time we're flashing the picture. Some things start to look familiar. And certain cisterns are reinforced. And emphasizing the jumbled up appearance if we do not dissect away the pia matter. Okay, so I think that ends part 2. If you want a 5-minute break, we can do so. Unless you have questions right now. So I'm checking the chat box if there are any additional questions. Okay, so no new questions as of now. Alright, we'll take a 5-minute break. So this is exactly how I feel when I have to lecture the brainstem. So almost there, but still a bit far away. So this part is about the cross section. So I really had to think hard on the sequencing here. But after we've looked on the outside of the brainstem, and I'll take a look on the inside. Well, there'll be some parts I'll not go into much details because I'll be revisiting them as I discuss certain parts on the succeeding lectures. So I really have to get this out. No, this is actually student-driven publication. So how to understand brainstem. So especially for med students, really you have to rely on mnemonics if you're just encountering this for the very first time. So some of the structures will not be familiar yet. So I'm just getting this publication out first. So 4 rules of the 4 brainstem rules for understanding the brainstem. So we will revisit each one of these structures later on. So rule number 1, in the midline, so letter M, there are 4 structures. So I have color-coded them as such. So you have this blue, you have this grayish one here, red, and yellow. So just for mnemonics wise and for Dr. Pascual modification of this, yellow stands for uh, motor fibers, right? And red stands for sensory, anything to do with sensation. Uh, the ones up here, blue means it's a voluntary movement by cranial nerve nuclei. And this one we'll get to in a while. So when we talk about motor nuclei of voluntary movements by cranial nerve gray matter inside the brainstem. So midline. So when we say midline, malapit sa gitna. So as such, they're in the midline. So here in the midbrain, here within the pons, and here in the medulla. So one thing to remember, not only are they near the midline, but they're also underneath the ventricles. So underneath the ventricles are the voluntary motor nuclei of the cranial nerves in the midbrain, pons, and medulla. Next. So gray stands for a connective fiber, uh, connecting those eyeball movement cranial nerves. So it's also found there in the midline, but beneath the voluntary eyeball or tongue cranial nerve gray matter. So medial longitudinal fasciculus is one of the few white matter connections I will over emphasize. Let's call it MLF for short. So it connects eyeball movements. Next, in red, is the medial lemniscus. So I said red earlier stands for me sensory. So most of the time in the brainstem, with exceptions, it's near the midline. So this is the so-called medial lemniscus. A lemniscus is also a very long connection. And it's also called medial lemniscus most of the time, although as it ascends into the midbrain, it's no longer medial, but it keeps its name because it's a continuing long structure. So I purposely drew them this way. So here it is a upright triangle. Here it is a mustache within the pons and a crescentic structure in the midbrain. So again, disclaimer, when you look at the actual brain specimens, you won't see this. Very difficult to see this because it is a white matter. But in certain larger areas, it is quite visible, like in the pons and even in the medulla, which is already a very tiny structure. So medial lemniscus is sensory. And then finally, motor pathway. This is the pyramid. Inside it is the pyramidal tract, which is destined for the spinal cord. But before it forms the pyramid, it is actually a jumbled up set of fibers here inside the base of the pons. Why is it so? Because the crossing fibers of the middle cerebellar peduncle split it into tiny bundles here at the base of the pons. Before it became this, it was actually this in the midbrain. It is a descending fiber tract. So it came from upstairs in the cerebral hemispheres, ended up here in the medial third of the cerebral peduncles of this midbrain here. So again, it's not in the midline though, if it's in the midbrain. So that's the pattern. Four structures in the midline. Motor nuclei, the MLF, the medial lemniscus, and the motor pathway. With the caveat, if you're talking about midbrain, it's not so midline anymore. So that's rule number one. Four midline M structures. So putting it together, that's how it looks like inside the brainstem. So this is how we ease you into that complicated anatomy of the brainstem. Rule number two. So if rule number one is about M's, rule number two is about S's. There are four S structures on the side as such. So a pattern in the spinal cord is maintained in the brainstem. Anything sensory other than that medial lemniscus is located dorsal and to the side, dorsal lateral in the brainstem. And this rule is maintained throughout the brainstem, not like the M's. So, putting it gently, so here within the medulla, okay, you have fibers from the spinal cord going to your cerebellum. It's a sensory fiber. It is located on the side. It starts with the letter S. The spinal nucleus of the trigeminal, one of several gray matter nuclei which control what the cranial nerve you know of as the trigeminal nerve control. So one of those several nuclei is this, the spinal nucleus of the trigeminal. What does this mean? Why is it spinal? Because it is a nucleus that goes all the way down into the spinal cord, which is very unusual, but the logic of this you will see quite soon. So that's the second S. So we have two more S structures. So here in the drawing, I labeled it as V, just to tell you that is trigeminal, or 5. Third of four structure with S is the spinothalamic tract. What does that imply? This came from the spinal cord and is destined for the diencephalon. So it came all the way outside and ascended the spinal cord to target the diencephalon's thalamus. This is what carries the pain that you feel. Spinothalamic tract. So it's an S, it is sensory, it is on the side. So in the brainstem, it is below that spinal nucleus of the fifth. And lastly, sympathetic fibers. So one of those fight or flight pathways that you will get to know soon. So sympathetic is the fight pathway, meaning excites you. So sympathetic, it's not a sensory structure, it is somewhere in between. Thus, it's not really on the side, but it is grouped on the side just to fit this rule. Sympathetic fibers. Rule number 3. So if the first rule was about the M's in the midline, rule number 2 was about the S's on the side. Now this is about the 4 cranial nerves in the medulla. I mean, okay, there are the rule of 4s for the cranial nerves. Okay, first of this, the rule number 3, first of the pair of the 4 cranial nerves is found in the medulla, is the hypoglossal. 4 are found in the pons. So, again. 4 cranial nerves in the medulla. So, correct. No? There are 4 cranial nerves in the medulla. It's 9, 10, 11, and 12. Highlighting the 12 because it is a voluntary cranial nerve matter, gray matter. So it's blue. The rest are not automatic. Although this one technically is, but it's not in the brainstem, as I told you earlier. There are 4 cranial nerves in the pons. Cranial nerve 5, which is mainly sensory with a bit of motor. Cranial nerve 6, which is a voluntary eyeball muscle, mentioned in rule number 1. And you have this mixed sensory and motor nerve in the face, and this pure sensory, special sensory nerve in the medulla. So 4 in the medulla, 4 in the pons. And then this is where the rule gets a bit complicated. 4 above the pons, so technically not just brainstem anymore. So again, obviously, non-neurologists made this. So there are 4 cranial nerves above the pons. So 2 of them are in the midbrain. the oculomotor and the trochlear nerves. And the other two, as you saw earlier, are the olfactory and the optic nerve upstairs in the diencephalon and the telencephalon. Okay, then rule number 4 is a bit of math. No? So, rule number 4 says that the four motor nuclei that are in the midline, which are 3, 4, 6, and 12, are divisors of 12, except of course for 1 and 2. So that means 3 is a divisor of 12, 4, 6, and 12. So these are also happen to be the ones in rule number 1, midline. So these are mnemonics which are supposed to help you consolidate the cranial nerves in terms of what they are on the inside of the brainstem. Okay, so that's the midbrain again. We slice it here because we're now looking at the cross sections. So this is how the midbrain looks like. Now the question is, to help it cement inside your long-term memories, is to answer this question: why is it shaped like this? Why is it shaped like this? What structures made it shaped like this? Why is it looks like this? Right. One thing that is frequently seen in a comforting thought. Once you see it, you know it's a midbrain. Is this dark band here, which is this one. That is the substantia nigra, the dark substance. Okay, this is how neurologists see it. So, how do we bridge it for LU3 and neurologists? It's so complicated. Even neurologists will lose their minds. So, we break it down. So, how do we get from this picture to this picture? First, we black things out. And then, now we can start. Definitely, this is cranial nerve number 3 because it comes out of the basal cistern or the interpeduncular cistern. Next, there is a component of the ventricular system inside, the tiniest part, the narrowest part, which is the aqueduct of Sylvius or the Sylvian aqueduct. So, a constant. So, slowly but surely, we start to put things in that we know are there, and that is the substantia nigra. So this is what we bare bones know about the midbrain, especially if it's a tiny structure you can hold between two fingers. So something like this looks like a square pants with a dark band. That is a medulla. Okay, then the sophisticated things come in. There will be a slightly pigmented oval thing here in the midbrain, just above the substantia nigra. Here it has been auto-dissecting itself due to the passage of time. Those are the so-called red nuclei or red nucleus. So a constant in midbrains. If you want to draw a midbrain from scratch, you draw something like a square pants. You add these two lines here. Then you add two ovals there near the midline. So those are the red nuclei. Then, to complete the picture, this fiber tract, which is actually a continuation from the cerebral hemisphere, the internal capsule that I was lecturing on yesterday is actually this structure here in the medial third, no, medial 2/3, or the 1/3 that is in the middle here. That is your continuation of the internal capsule. Then that structure that we mentioned earlier in the rule of fours, which I said looks crescentic inside the midbrain, which is actually this one, depends on how discolored the specimen is. That is the medial lemniscus. So what it does, Dr. Sang will mention it, and I will mention it also next time. Then up here, so it is gray matter. This is actually what I showed you earlier. That is the superior colliculus. Or depending on the cut, it might be the inferior colliculus. Then the fibers of the cranial nerve 3. They are not always seen unless you cut it that thinly. You might barely see these fibers here crisscrossing through the substantia nigra to exit as the cranial nerve 3. So, with our drawing combined, uh, then we have something like this. Basic midbrain structure. At your level, mainly, you want to remember just this. No? Square pants with a dark band here, substantia nigra. That is a midbrain shape to put into your heads, no? To remember the medium. Why is it shaped like this? Because of the white matter, which is large. Sorry. Okay. Then with the help of a myelin stain. So myelin stain will stain for white matter. So the white matter stands out, compared to a plain formalinized specimen in our laboratory, which will show you better white matter of the third nerve and white matter of the cerebral peduncles, which actually are continuations of the internal capsules, anterior and posterior limbs. So we cut it here. So I mentioned depends on the cut. Now, what if you cut the midbrain here at the inferior colliculus, very close already to the pons? So you see there's a difference now in shape between upper and lower. So it still looks like a square pants. You see those in a dried up specimen like this. You see the red nuclei here, the substantia nigra here, but right beneath it, it starts to be fatter, no? Larger belly over here. Then you know this midbrain is starting to give way and become the upper pons. It is still a midbrain because you have substantia nigra here, the red nucleus over here, and that cerebral aqueduct because the cerebral aqueduct is only found inside the midbrain. Okay, you flip it on the other side, you start to see the beginnings of the fourth ventricle. So it looks like a pons and a midbrain hybrid, but it's more pons now than midbrain because there's no more substantia nigra. And the gray matter that are usually seen in the pons start to appear here. Okay, so that's the lower midbrain. So with the myelin stain, this area around the cerebral aqueduct is actually a very important structure in terms of making the pain less painful. A part of the pathways that dampen pain. Here, gray matter, that is your colliculus. Not sure if it's inferior or posterior. Alright? Then, here are white matter bands. So we said the cerebral peduncles are actually continuations of the internal capsules, anterior and posterior limb. Now here, whereas it was quite distinct in this part, this is all white. Once you reach down to the lower midbrain, it starts to break apart. So here, the motor fibers start to break apart as they are dispersed by the crossing cerebellar fibers. So distinction. Now, once you reach here, we've cut the brainstem into its transition into a pons. This is now more pons than midbrain because the peduncles here are already dispersed into smaller bundles here by those whiter pontocerebellar fibers, which are destined for the cerebellum. So I mentioned that the belly is mainly caused by the crossing fibers going towards the cerebellum. That leads to its very belly up appearance, a very big belly. Right, so this is a upper pons. That is a fourth ventricle over there. Okay, now we zoom up on this particular upper pons and marvel at its appearance. But then, as an LU3 student, how do you make sense of this? So these are two pontine specimens. So what is distinct about the ponds are these two beady eyes over here. These two dark patches, if we had substantia nigra as the dark bands on the midbrain, these two dark circles here are only seen in the ponds. So what does this mean? They also produce a chemical that is important for our fight or flight mechanisms. So more on that when I lecture on the limbic system, but suffice to say, this is the source of all your adrenaline. Your norepinephrine comes from these two structures here. So zooming in, this is a pons. Why is it a pons? Because it has a big belly, right? So we blot everything out and put what we can remember. So this is an upper pons with two beady eyes here. It has a scarf. You see this dark band here is actually the medial lemniscus that we saw earlier. This is sensory. It is midline. And then you have the crisscrossing whiter fibers going towards the cerebellum. And we have the descending browner looking fibers going down towards the pyramids. So why is it brown? Because we're looking at these fibers cross-sectionally. Whereas these pontocerebellar fibers we're looking at longitudinally. So the glistening white is actually myelin, the insulation of the white fibers. Thus they appear as whiter compared to cross-section where you can only see on microscopy a rim of that myelin sheath. So here, comparing now with a myelin stain, so it corresponds. No? These are white matter transverse, those white ones here, and the browner ones are these bundles here, which are cut cross-section. Both are white matter, both look differently because they have been cut at different angles. And then we look up here, this is white matter, that is the medial lemniscus. There is a white matter here as well. We'll discuss that when we talk about the limbic system. Right. Now, as we cut and cut and cut, the pons slices look very, very similar because it's really a really big mass of tissue here. So we get a representative cut now here at the lower pons. See, it's a lot different from the pons up here, upper versus lower. So instead of being oblongish up here, it becomes quite rectangular or rhomboid appearing here because these are the middle cerebellar peduncles. And then these dark bands you see here are actually cranial nerve fibers traversing the base of the pons to exit here laterally or here medially, depending if it is an abducens or it is a facial nerve. So more on that later on. So here's that complicated picture for neuroanatomists or neurologists to look at. Everything is here. But do you need to know all of this? No. So we break it down. We blot everything out and say what is important in the lower pons. So first is we know that the fourth ventricle is above it. Therefore, we know that there is a voluntary cranial nerve nuclei, a pair of them here near the midline, based on the rule of force. So here are my representations of the abducens nuclei, cranial nerve nuclei. Their neurons are found here, and their fibers, their axons, are the ones that form the peripheral nerve that you see when they exit. Not seen in this specimen. Then you have the other cranial nerve, which is 7. Cranial nerve 7 exits laterally. But the special thing about the 7 is, for some unknown reason, its fibers encircle around the 6th first before it exits. The reason for which I do not know, but it does that. There's no reason for it to do so, but it does. Maybe it's avoiding something here. I'm not quite sure about that. Then you have the mustache. So the mustache here is the same mustache we saw earlier. This is the mustache of the medial lemniscus. And then down here are the bundles of the pyramidal fibers, the pyramidal tract fibers. So we put things that we are familiar with first. The rest, if they're too obscure, we just leave them out. So this is how we draw the lower points with all the important structures inside. The motor fibers of the pyramidal tract, which were dispersed by the massive middle cerebellar fibers. That could be a reason why the seventh nerve looped around first, because it's too complicated there. And then the sixth nerve that is located medially beneath the floor of the fourth ventricle and exits near the midline. Alright, so that's the lower pons and the myelin stain of the lower pons, showing you the seventh nerve and the sixth nerve over here. So the nucleus, which is pale staining here of the seventh, in its fibers, for some inexplicable reason, does not just go straight out here. It goes around the sixth nerve here, loops around it, and then goes back laterally. What is it trying to avoid? Not sure. If it's the massive pontocerebellar fibers here, you have to find a way to get around them or around the medial lemniscus. So it has to find its way out. And then once we get here to the lower part, we're now cutting the pons where it starts to transition into the final segment, which is the medulla. So this one, we cut the next slice, it actually looks like this. So the flip side of this looks like a lower pons, but the other face looks like a medulla. So what does the medulla have? It has pyramids. So two different specimens, one older, one newer. This is from a autopsy. This is from the patient, the people that we have in our swimming pool of formaldehyde in anatomy. So two different pyramids, two different olives, somewhat similar looking medial lemnisci here. So how do we get to this? We show first the detailed neuroanatomical picture, and then we mentally subtract everything out and compare it with this specimen over here. So we blot everything out, then we put in what we know. And for the medulla, we know that there should be pyramids. So there should be pyramids, all those dispersed bundles from the internal capsule that went into the cerebral peduncle of the midbrain that were dispersed by the massive pontocerebellar fibers started to come up together again, and in the medulla they again form one cohesive set of white matter, which are your pyramids. So why is it brown? Because as I mentioned earlier, these were cut cross-section, meaning this set of white matter were also cut cross-section. That's why they look brown. Here on the sides are the olives. As you will, well, unless it has been already mentioned by Dr. Baticolon, these have to do with your cerebellar system. So these are the olives. And then we know that the medial lemniscus sits perched on top of the pyramid. So this is sensory, it is in the midline. And at this stage, at this level, the only voluntary cranial nerve nucleus is that of the 12th cranial nerve. So with nothing to stand in its way, it just goes straight down, exits there at the sulcus between the pyramid and the olive. So it inserts its way and exits there. So we put everything together, and that is more or less our basic understanding of the medulla. Very, very basic, meaning we have not put in yet the structures that are responsible for our daily living, basic life processes. So where would they go? Everything else here. Right. So medulla, myelin stain. The pyramids are down here. The medial lemniscus or medial lemnisci are up here. These two are the gray matter of the olives and their connections with the cerebellum. And this one is the hypoglossal nucleus or nuclei. So as we cut lower, the medulla rounds up, becomes more oblong and rounder until it starts to look like a spinal cord. So this particular cut is a fortunate cut we made that is right above where the crossing starts from the pyramids to the opposite side of the spinal cord. So the crossing of the pyramidal tract is just beneath this slice. We know it is still medulla because of the pyramids and the medial lemnisci. But here, as we descend, there's no more cerebellum when we reach the spinal cord. So the olives start to disappear. And then we get a new set of gray matter appearing here, which have connections with the spinal cord. So the final cut of the caudal medulla, which is totally different, it's after the obex at the floor of the fourth ventricle. So this is the neuroanatomical picture. Survival guide for LU3 is to shut things out. Remember what's important, the pyramids, what remains of the olives, the medial lemnisci, and then what forms the medial lemnisci are the gray matter over here. So this ascending fiber tract actually came from here, and at the lower point another pair of nuclei on the side. So these are the nucleus gracilis. So you'll get to know that better when we talk about the somatosensory pathways. But long story short, it carries the light touch and the pressure and the vibration sense that we feel from the spinal cord up into the brain stem. So the nucleus gracilis and the nucleus cuneatus next to it later on. What it does, you'll find out soon. And then here, ascending from the spinal cord are the sensory fibers I mentioned earlier in the rule of force. This is the spinothalamic tract. So put them together. This is the basic caudal medulla, meaning there's no more fourth ventricle. At your level, maybe just these pyramids, the medial lemniscus, and the nucleus gracilis up here. This one is the so-called nucleus cuneatus, which carries vibration sense from your arms up into the brainstem. So these are from the legs, gracile, gracilis. And that is a superimposed picture on top of those complicated structures inside. So putting it together, the general structure of a brainstem, there has to be a base which has those motor fibers. There has to be a roof. Most of the time it's absent. It's just the cerebellum that makes the roof, but only in the midbrain is the aqueduct really enclosed by a tectum or a small roof. So what I mentioned by everything else, which is tegmentum, this is the everything else that you see here at the core of the brainstem. These are where your cranial nerve nuclei are residing. These are where the controllers for your breathing, your blood pressure, your heartbeat are all located. Basic things, your ability to control your bladder, your bowels, all inside here. Okay, so that's the basic architecture. These slides are just shown again to show the aqueduct The only slice where there is a tectum. Everything else, there is no tectum, but the cerebellum stands in its place as the roof of the ventricular system. Right? So the basic pattern in the everything else pattern, motor is here in the ventral part of the brainstem. Sensory is always dorsal. Especially the more special the sense is, the more dorsal it is. The special senses of hearing and taste, as far as the brainstem is involved. As you go here closer to the middle, like those voluntary cranial nerve nuclei, these are what moves. So everything inside your heads, your eyeballs, your cheeks, your facial expressions are all here located close to the midline. But the more closer it is to the midline, it is voluntary. As you go more and more laterally, it becomes more and more automatic, meaning you have no control over it anymore. You cannot control the actual projectile vomiting that you do. You can induce it, yes, but the actual act is already involuntary. And the most involuntary of all would be that sympathetic fibers that I mentioned earlier, meaning these are totally autonomous in their actions. You don't need to think about it. You will defecate, you will urinate, you will breathe. Your heartbeat will speed up or slow down depending on the situation. Yeah, and everything in between, the so-called reticular formation, everything automatic, even your wakefulness depends on that reticular formation. That's why it deserves its own lecture. Right? So these are the different slices set in more or less chronological order, from the midbrain to the pons, to the lower pons, to the medulla, and even up to the spinal cord. Right? And this is just to emphasize the square pants. An upside down square pants, and the legs that actually come out from the medial third of those cerebral peduncles, just to emphasize where the motor pathways pass through. The medial third. And that's an even nicer specimen with the substantia nigra. The cerebral aqueduct, the peduncle here. Again, emphasizing the medial third for the motor fibers. Alright, and just flashing the slides. So this picture is shown to you to emphasize that sometimes the brains are not cut the way we would want it to be. So this is a cut where the midbrain thalamus junction is, as well as the cerebral hemispheres. Which has emphasized my point from yesterday. It's really artificial to separate these things from each other. So they're all interconnected, which makes teaching neuroanatomy quite difficult to make it simple enough for you to understand. Right? So part of the diencephalon there. So just in passing, because I'm not sure if it will be covered by Dr. Robignol. So the red nucleus is an older version of what we're using right now. So these are found in quadrupeds. So this controls your shoulders and your thighs. Important for running for quadrupeds, but not so important for us bipeds. Okay. Of course, early in life, it is more useful to us, this red nucleus motor pathway. So, whereas we had the corticospinal tract, which is newer, this is older, the reticulospinal tract. But it is our fallback mechanism in case you have a stroke. So, you see people who have a stroke initially cannot walk, but eventually learn how to sit and stand once again, once we've harnessed the plasticity of the brain. right? So quickly flash through these slides. I think just emphasizing. So substantia nigra, you will find out its importance as we go to the basal ganglia circuitry for weeks from now. But we mentioned dopamine. So dopamine is your motivator. We have a motivator for movements, and we have a motivator for getting by each day through medical school. Okay. And just showing you that motivator. Again, you do not see this on cut specimens. You don't even see this much on plastinated specimens. But it's very important for us, no, if, for OS202, we always like to mention what gets you through each day is the dopamine that is produced here at the base of the midbrain, the so-called ventral tegmental area. So it's in the tegmentum. It produces dopamine just as the substantia nigra does, but this has a different target. It targets your cerebral hemispheres. It targets your limbic system. This makes you wake up, get out of bed each morning. What motivates you to go get to the next day, right? So more on that when we get to the limbic system. So splashing through these slides to see what's important for you. This one, no? So the startle response is partly visual and partly auditory. No? So trigger warning, sorry. The trigger warning came in after showing you the picture. So the colliculi are responsible for that startle response. So usually this picture would be accompanied by some loud screeching violin music. The MLF that I showed you in the rule of fours is also not visible unless you have a special stain for myelin. So as I will teach you in the motor cranial nuclei lectures, this is what connects your eyeballs together with your cranial nerve 8. Why it's connected to your cranial nerve 8, you will find out soon enough. Right? So just flashing through. And some of these you'll see the importance of next time. So this one will be lectured by Dr. Seng. I just had to mention it because it's inside the brainstem. Another point saying that we are all interconnected with our topics. So again, the mnemonic I came up with is the mustache in the pawns is actually similar to the mustache of the Pringles logo. And that set of black dots in the pawns are actually the producers of norepinephrine, the so-called locus ceruleus. It produces everything, the norepinephrine that energizes you from such a tiny structure. Right? So mnemonic here is the P picture, if you get me. Okay, so this is how extensive that tiny little set of dark sustained matter actually connects to your entire your entire CNS. Okay, this is how it fired. I don't know where you were this whole afternoon. If your locus ceruleus was firing or what is it? Was it minimally firing? Means you're just living but not awake. It's abolished when you're sleeping. Okay, such and in younger people, it is a lot easier to shut down. Okay, just flashing this here because I really need to get this out there. Your norepinephrine has its limits, no? So in people who have gone through so much, it can be depleted, and it can result in partly responsible for what we see in post-traumatic stress disorder. Right? Just keeping to the time. It's 3:30, but I want to see if there anything else I need to emphasize here before I give a summary set of slides. Because I will be covering this again when I lecture on the motor cranial nerves. Okay, this one. So I mentioned some cuts of the lower medulla can actually look like spinal cords already. And In some special specimens, if you're able to catch them, we actually see the crossing over of the fibers to the opposite side. And okay, while I'm here, I failed to mention those bumps, no, at the back of the medulla. So I mentioned it in the cross section. The nucleus gracilis is where the terminations of those fibers for light touch, pressure, and vibration end in the at the lower medulla before they give rise to the medial lemniscus. So on the outside of the brainstem, it actually forms a bump. No? So we have a name for that. It's called the clava or the grass cell tubercle. I'm sure you've seen this word before in OS203. It means a bump in something very long. Okay, so that bump over there corresponds to the nucleus gracilis. Right. Decussation, you'll be very difficult to find on the internet a picture of the decussation. So I'm left with just pictures, no, putting arrows where it's supposed to be happening at the junction of the cervical spinal cord with the lower medulla. All right, and I think, which leads to the last one. So 30 minutes should be enough for this. So you have any questions at this point? The chat is silent, so I guess you must be very tired. So we end with this easier. Okay. I will give you this one first since this is fairly lightweight. Just to connect with those rule of fours. And to emphasize that the brainstem is actually a connector. It's a connector with to the spinal cord. So movements. So this actually are your brain and the peripheral nerves acting as one. So your motor fibers, your facial expressions, eyeball movements. Okay, so motor, all of these pass through the brainstem. Pain, sensation, and modulating it, you will see in the limbic system and reticular formation lectures that there are centers in your brainstem which produce serotonin, a very important hormone to get you through what you're going through. If it's depleted, just like the dopamine, then it leads to a state of depression. Right? So, pain. A concept that you will understand later on when you get to see patients is putting it all together. So, if you get a person, you examine that person, and you see mostly abnormal cranial nerves, but they're perfectly walking around normal strength in their extremities, might be on the outside. So we have this concept of outside the axis of the central nervous system, meaning it's coming from the outside, or if it's coming from the inside of your brainstem or your spinal cord. Aside from the abnormal cranial nerves that you will be testing, there is also involvement of the motor pathways or the sensory pathways or both, or even the cerebellar pathways. So a picture you will need to revisit next time. So I introduced to you what's inside the brainstem. Putting it all together will take some time. So these are just different terms to refer to it. If you're talking about spinal cord, instead of using extra eggshell, we use extra medullary, and inside the substance, it's intramedullary. Okay, this was done upon request of one of the students before. I think they're graduating now. So the batch of 2023. Okay, so uh, emphasizing in pre-med, the lectures only stopped here as to cranial nerves. or what's on the outside of the brain, the brainstem. What I was trying to start in you, starting today, is that they do not end here on the outside. They go inside into their gray matter. So that gray matter controls whatever that cranial nerve does, whether it receives information or it produces an action, right? So our state of consciousness is inside the brainstem. So you'll understand this when we go into the reticular formation lecture. That's what's inside your brainstem. You have your motor system, you have your sensory system, and you have your wakefulness system, as well as your neurotransmitters for emotions. Okay. Sensory would be going back to your cerebral hemispheres for processing. Downwards would be actions planned by your cerebral cortex to produce an action. And the concept of crossing. So when I mentioned yesterday that you have one hemisphere dedicated to half of your interpersonal body space. Your right brain controls your left body, your left brain controls your right body. And you are not two people in one, no? You're a cohesive person. So the decussation exists because of our bipedal nature, also because of the nature of our eyes, because everything's inverted. I will try to explain this in detail later on, but just to say there is such a thing as crossing. So what we saw earlier, the crossing of the motor fibers happens beneath the brainstem, right at the spinal cord. You will learn soon enough about sensory tracts crossing as well. So introducing it here so that it's not alien to you the next time you encounter the term decussation. I mentioned about a logical arrangement of the fibers depending on where its targets are, if it's to the legs, to the arms, or to the face. So inside those fiber tracts that you will be learning about, whether it's the corticospinal tract or the spinothalamic tract or the medial lemniscal tract, there is a representation of your body inside each tract, although it is just half of your personal body space and it crosses at some point. Okay. The thing about the brainstem, in opposite to the cerebral hemispheres, is that the gray matter is now on the inside, while most of the white matter is on the outside. It makes it a lot difficult to see on unstained brainstem specimens. What's on the inside, the nuclei that I mentioned earlier that controls all those 12 or the 10 cranial nerves that we were talking about. The reticular formation, which controls the automatic processes, as well as nuclei which have to do with the cerebellar system in terms of balance, and the white matters on the outside, which are either descending or ascending, or they crisscross and connect structures within the brainstem itself. So you will get to know the reticular activating system, which is connected to those locus ceruleus, which keeps you awake. You will get to know the spinothalamic tract, which sends up sensory information from your skin back to your brain. The medial lemniscal dorsal column pathway, so this is a spinal cord brainstem pathway which is in charge of the light touch. These ones you will learn from Dr. Batigalon, the special senses, as well as the cerebellar connections. Okay, so a schematic of how interconnected everything is. Very difficult to assign different lectures to midbrain, a lecture on pons, because you will lose sight of what neuroanatomy is all about. Okay. So how interconnected that reticular formation is in terms of your wakefulness. So Dr. Dasig or his appointed successor will lecture to you on the how the brain works. I think he will still lecture to you on this part on neural control. Right? And I will mention a bit of this in my reticular formation lectures. Right. So you'll find out how your neurotransmitters are very much linked to who you are as a person. So every one of you are distinct individuals, different personal experiences, different body makeups, different levels of dopamine, serotonin, norepinephrine at every different point in time. That's why we individualize how we teach neuroscience, right? You'll understand this next time. I will not lecture to this right now unless you ask for it next time. No? Okay, so more on this on the last few lectures of neuroanatomy. Okay, so we'll just dedicate the last few minutes for questions if you have any. Any questions so far? Okay, so you can send your in. I think I put in a Slido there in the canvas, no, for questions that you wanted to ask. So there's a lot of information just now that is a lot to process. No? This particular lecture I skipped because I feel it is not. It will not do justice to the lecture. I'll just flash the slide just to show you. Well, I finished my brainstem lecture and you survived it too. So, see you in the next few days.
Doc, hello po. I think Hannah Babaran has a question.
All right.
Hi, sorry. Um, Hi, Doc.
Yeah.
I yeah. Okay, so since OS204 po kasi, na-mention po talaga yung decussation. And I understand that it has like an evolutionary benefit for like the protection and stuff. But I would just like to have like an expanded explanation as to why it's important, especially for us. Yeah, in our functioning. Like
All
why
right.
can't it just go straight?
Okay. So, think of it this way. I'm not sure how detailed the eye lectures were, but they did mention that your lenses produce inverted pictures. Do you remember that? Okay, so imagine whatever your retina sees are upside down, flipped left-right pictures, right? And we are bipedal animals, and every one of us has a nose. Now, if every one of you who are still awake can close one eye and just look what's ahead of you, does everyone see their own noses? So a skill you will learn in OS202 is how to close one eye without using your hands. No? So if you close one eye, especially if you take off your glasses, you would see that your nose occupies a significant portion of the picture of that eye. Now, if you open both eyes, your nose disappears, sort of. Unless you intentionally look at it, you will no longer see your nose. Why is that? Because you're now putting together two different pictures from two different tracks from the eyes. Each track has only half of the vision for a reason. So one half of that track will persist on the same side. It will not cross. So it saw the other side of the picture. Whereas the nasal half of your retina saw the temporal halves of the picture, and it is split into two brains. So you have a copy on both sides. So that what happens, your brain does some remixing so that the nose disappears. Now, because of that setup, where one half of your brain sees half of your personal body space. Now, which arm, if you had to contend with your left personal body space, which hand would you use? The left or the right? So imagine, uh, and you would have experienced this if you had the stroke or you had the brain tumor, but we don't want you to do that. Uh, Imagine that you lost half of your personal body space. No? So let's say you lost all control of your right personal body space. Would you be able to use your right hand? Let's say if you cannot see what's on your left side, can you use your left hand to do things? You cannot see anything on your left side. You cannot do anything with your left side unless you intentionally turn your heads. No, so if you lost your left personal body space, what would be a useful hand to handle it? You would have to use the other hand. And what this hand belongs to the right personal body space, which your left brain could see. See? And it so happened language development occurred here on the left side of the brain. No, so it is a evolutionary development to have decussation as a backup. No? Only animals which are quadrupeds do not have cross uh, tracks. They're all ipsilateral. Even the vision is not crossed. Their optic, since I mentioned, the eyes are actually extensions of the brain. The optic nerve goes straight to the same hemisphere. So whatever the reptile sees on the left side, the left, uh, the left claw deals with, and whatever the reptile sees on the right claw deals with. And it's mostly it's just moving. It doesn't need specialized movement since it has only reticulospinal tract, so it can only crawl. No special, no special movements required. But if you're a sophisticated animal already, like a cat or a chimpanzee, you would have already developed a more or less your nose is not as long as the other animals are. So you can see both fields. No, you're a binocular animal. That's the time because of the nose. No, so you need a copy on both sides. So I don't know if that's enough explanation for you, but I already made slides for that, but it's not my assigned anymore. It's not my assigned lecture anymore. I already passed it to Dr. Baticolon. Here in the
Thank
chat, there's a question about plasticity. Unfortunately, the brainstem is not as plastic as the cerebral hemispheres because the neurons are really uh, assigned. It's a very small structure with very small assigned neurons. Once you lose your swallowing neurons on one side, it's very hard for the neurons on the other side to control because it's already next to its end target, which is the cranial nerve. Compared to a problem in the cerebral hemispheres where neurons can rearrange and take over. Okay, any more questions? The Slido if there will be any questions, and I'll get to them the next time I lecture to you. So with that, rainy afternoon. So thank you for staying. Thank you for listening.
Thank you so much, Doc.
Thank you.
Thank you.
Thank you, Doc.
Thank
Yes,
you.
the
Doc.
Thank you.